Good morning, everybody. Welcome to the Cell Talk presentation. Today, our presentation will be done by Uma Rakshita. The topic for the presentation is Application of Artificial Intelligence in Lung Cancer Screening, a real world study in Chinese physical examination population. It is going to be presented by Uma Rakshita. Let me give you a brief intro about her. Uma Rakshita is a research intern at Renix Life Sciences. She is working on the multiple projects which includes gene maps and success of clinical trials. Gene maps involves data collection related to gene panels and a literature search for gathering information related to gene associated diseases and their treatment. Success of clinical trial involves collection of information related to drug details, scientific details, clinical trials, publications, and financial details of new approved drugs. She is also involved in organizing and handling the Cell Talk Journal Club presentations and other social media related activities. She has completed her Doctor of Pharmacy program from Nirmala College of Pharmacy. Before joining Renix, she worked as a drug safety associate in Pharma Console Private Limited for the project company core datasheet. At Renix, she has gained an opportunity to develop leadership qualities and to explore and learn new areas of interest.
Thank you, Yash, for the introduction. Good evening, everyone. Today, I'm going to present on the title Application of Artificial Intelligence in Lung Cancer Screening, a real-world study in a Chinese physical examination population. The topic selected was Artificial Intelligence in Cancer, and the article was published in the journal Thoracic Cancer, which has an impact factor of 2.4, 2.3, and it is published in the year 2024. This research has an impact on lung cancer screening and artificial intelligence. So coming to the introduction, lung cancer is considered as like one of the leading cause of cancer death and was the top priority of cancer prevention and treatment. So internationally, low-dose computed tomography screening has emerged as a golden standard method for treating, like for diagnosing lung cancers, because it provides early diagnosis and to get clinical interventions. With rapid increase in the chest CT images, the workload on the radiologist has been increased. Fatigue and proficiency expertise in among the radiologist has led to missed diagnosis, and regional disparities in clinical outcomes. Hence, the use of AI-assisted image-assisted diagnosis system in clinical treatment has become a major trend in medical development. So, effectiveness of lung cancer screening through chest CT scan was compromised when dealing with small subtle lung nodules, and also the lung nodules that were presented located in a challenging anatomical areas such as bronchus and hilum. In this context, use of automated detection methods was highly desirable. China has issued a series of policies on AI development planning. With the support and encouragement of these policies, the future of clinical treatment is set to increasingly rely on AI-assisted imaging diagnosis system. So this AI image assisted diagnostic tools provide multifaceted beneficials such as reducing the workload on the radiologists, as well as to decrease the instances of misdiagnosis or missed diagnosis, thereby helps to get accurate and correct results within the stipulated time period. Present challenges with increase in the significant rise in the number of chest CT scans, due to improvement in living standards and increased focus on health, that there was like challenging inaccurate analysis of large data sets and substantially increasing radiologist workload and creating a professional shortage. Objective of research. This study focused on exploring the value and the diagnostic accuracy of the current AI that was employed in the clinical application. It aimed to compare the detection and differentiation of benign and malignant pulmonary nodules between the AI system and the physician's interpretation. So coming to methodology, study designs and participants. This study was conducted from June 2013 to September 2016 and included a total of 23,336 participants who have undergone chest low dose LDCT screening for lung cancer at Health Management Center of West China Hospital. This study included participants who were overall 40 years of old and has high risk factors for lung cancer such as smoking, passive smoking, as well as environmental or any occupational exposure, any condition like COPD or any history of lung cancer. Exclusion criteria. The study has excluded the participants who has any pre-existing lung conditions such as diffuse metastasis, extensive patchy lung consolidation, pulmonary nodules of indeterminate nature, etc. And utilizing a chest LDCT scan of a healthy individual, screening positive rate was established. So in this study, both AI-assisted reading as well as manual interpretation methods were employed to evaluate and detect the malignant lung nodules. Along with this screening, parallelly, they have conducted detection rates of lung cancer. They have analyzed the detection rate of lung cancer. So this is a flow chart showing the overview of the study. Initially a baseline screening was conducted from June 2013 to September 2016, and this round was considered as like T0, which included participants of 23,336. After this, by the end of final follow-up period, a total of 5 more rounds have been was conducted for screening the lung cancers. During each round of screening, comparison of manual reading and AI reading was done in each round. Analysis and recording of images. All the participants have underwent LDCT scans using Soma-Atom double slice spiral CT, and the lung scan ranged from lung apex at the thoracic entrance level to the lower margin of the bilateral costophrenic angle. All the CT images that were created were stored archived in PACS. Judgment of image results by manual diagnostic system. In manual diagnostics, manual diagnostic team, two main radiological experts having having experience of about 5 years in analyzing the chest CT scans, along with other team members were included, and they have recorded detailed information about the lung pulmonary nodules that included layer number, location, density, size, shape, internal characteristics such as whether the nodules have cavities or whether it is calcified or non-calcified, and marginal signs such as margins were smoothened or any speculation of a present. And according to the study screening criteria, the population that were included was divided into 3 groups: screening positive, screening negative, and screening highly malignant. Screening positive included the participant whose lesions have potential for malignancy, and the size of the lesion was more than 3 mm of size. And if the mostly those lesions were tend to be non-calcified lesions. Coming to screening negative, the participants whose nodules were calcified and have less potential for malignancy, and they have they don't have any much abnormal findings. And coming to screening highly malignant, nothing but the lesions have complete malignant characteristics, or those participants who has recommended for the shorter period of follow-up, shorter follow-up period. So judgment of image results by the AI system. So DICOM image files of chest LDCT that were created were imported into chest CT image assisted diagnosis system V 7.3.0. That is in this study, chest CT image assisted diagnosis system of version 7.3.0 zero was used, which was provided by Hangzhou Ito Medical Technology. And this system has like automatically reported the like characters parameters of the nodule, such as position of the nodule, size, density, and its probability, malignant probability. So this is like a one sample CT scan of like a lung cancer participant. Like this A film shows the interface of the lung window. B film shows the interface of the mediastinal window, and here this shows the 3D dimensional, like three-dimensional image of lung nodule. Coming to statistical analysis, all the statistical analysis in the study were done using SPSS of version 2020, like 22.0, and the results were considered significant when the p-value was less than 0.05. Coming to the result parts, table 1 shows the analysis of baseline characteristics of healthy LDCT lung cancer screening population. So here a total of, in this study, a total of 23,336 participants were included, in which males were like 13,865 and females were 9,471. The average age of the participants during the enrollment into the study was found to be 45 years plus or minus 12, and about 30.7% of participants were considered to be smokers, and 2.9% of participants have a family history of lung cancer, and 2.2% of participants have chronic lung cancer disease. Results of chest LDCT screening in healthy people. So a total of 176 cases of lung cancer were detected in this like from the study, and the detection rate of this lung cancer in healthy population was found to be 0.8. The final follow-up date was done at like on October 1st, 2021. So before this follow-up date, as we already discussed, like total of 6 screening rounds were conducted from which included even baseline screening T0 to T5, and along with this, comparative analysis of manual interpretation reading and AI reading was also done for each round. So in each of the 6 rounds of screening, positive rate positive screening rate was observed predominantly in AI group when compared to the manual interpretation. Similarly, the probability of evaluating the malignant pulmonary nodules was significantly high in AI screening group when compared to the manual screening group. Next, detection of malignant pulmonary nodules by manual and AI reading. So this table shows we have already discussed, right, like a total of 176 cases of malignant pulmonary nodules were identified. In that, manual reading has detected about 152 cases of malignant lung nodules, whereas AI has detected 171 cases of malignant lung nodules, and about 24 were missed by manual reading, and 5 were missed during AI reading. So the detection rate of malignant pulmonary nodules by AI reading was significantly higher than that by manual reading, and the difference was statistically significant. So table 3, this shows the comparative analysis of malignant pulmonary nodules which were missed by manual reading as well as the AI reading. So we already have seen that right in this table. Sorry. So in this table, about like 24 were missed under manual reading and 5 were missed in AI reading. And similarly, the average time for detecting the average time of missing malignant pulmonary nodules by manual reading was about 3 years, and by AI was about 2.9 years, and the average size of missed malignant lung nodules by manual reading was like 6.38, and by AI reading was 5.64. This table shows the detection of lung cancer by chest LDCT in different screening result group. So out of 176, through manual reading, 159 cases were considered to be screening positive, and 174 cases were considered to be screening positive by AI reading, through AI reading. So the detection rate of lung cancer in AI positive group was significantly higher than in the manual positive group, and the difference was significantly statistically significant. So this table shows the pathological characteristics of lung cancer with chest LDCT in different screening result groups. So here, under manual reading, a total of 159 cases were considered to be screen positive, and in AI reading, a total of 174 cases were like considered to be screening positive under AI. So in this 159, again, like most of the cases were grouped under stage 1A, and in that too, again, mainly they were many of stage 1A1. Similarly, the same case was there in the AI rating. But when we see here, the number of cases were higher in AI when compared to the manual interpretation. Detection of AI1A1 lung cancer in different screening result group of chest LDCT in healthy group. So here they have considered the only the 1A. Here it is like, right, 66 1A1 cancers. In that, again, they through manual reading, 559 cases were found to be screen positive, which was less when compared to AA reading, which is like 65 cases. Okay. So the detection rate of stage 1A1 lung cancer in AA positive group was significantly higher than in the manual positive group, and the difference was statistically significant. So this table shows the histological types of lung cancer in different tumor stages detected by LDCT. So if we see, like, most of the majority of the cancers were of adenocarcinoma type, like out of 176, majority were like 130 of adenocarcinoma type, and in that too, again, they belong mostly to AA1 and V club. Mostly they were into the stage AA1A. Majority of adenocarcinoma can be detected at stage 1A. A total of 176 cases of lung cancer and 130 cases of adenocarcinoma were detected, of which 96 cases of adenocarcinoma was stage 1A. Follow-up results. The follow-up began in June 30, 2013 and ended in October 1st, 2021. The shortest follow-up time was 0.1 years, and the longest follow-up time was like 7.9 years. The mean follow-up time was found to be 3.2 years. One patient died, and the cause of death was lung cancer. Coming to the discussion part, in recent years, AI technology based on deep learning has gradually shown its superiority in the medical field, especially in the field of lung nodule detection. Some studies have shown that the AI system outperforms the imaging physicians in the detection rate of lung nodules. A study conducted by Pan et al. Has found that like the time required for AI to read the film, like scan CT film, was statistically shorter when compared to the manual interpretation, suggesting that employing of an AI can reduce the patient diagnosis time as well as the waiting time. As deep learning models were developed through extensive data training, the results that were produced by these models were like more robust, and they were like scientifically grounded. Compared to traditional diagnostic methods, so these modules reduce the diagnostic errors associated with variability in physician expertise, thereby enhancing the accuracy of determining the relative positions and the malignancy of pulmonary nodules. Coming to limitations, two limitations were there. This study is a single center retrospective design. So and it shows a need for opting for a multi-center prospective design in order to investigate, in order to validate the results of the study. And the analysis, usually the tool, the AI tool that was used in the study was provided by Hangzhou Itu Medical Technology, which indicates that these results may not apply to other AI tools. Hence, usage of application of various AI tools in future, application of various AI tools and validating the result is required. Conclusion, this study indicates that AI assisted reading has superior positive rate and lung cancer detection rate when compared to manual interpretation. Thus, AI exhibit considerable potential as an adjunctive tool in lung cancer screening within clinical practice settings. Impact of the study, the research suggests the need and importance of employing an artificial intelligence assisted diagnosis system during LDCT screening for pulmonary nodules help to enhance the efficiency and to conserve time and the resources. In future, manual interpretation can be combined with the AI. AI and manual interpretation can be combined to give diagnostic efficiency, improve the diagnostic efficiency of pulmonary nodules and make optimal clinical decisions. Thank you.
Thank you, Uma. If any of the participants have any doubts or any questions, you can please turn on your mic and then ask. Okay, I think there are no questions for you, Uma. Thank you.
Thank you.